Uh, First of all, I'd like to thank the GIS board for inviting me to present one, not at least many complications we have every day, maybe every month, but you need to learn from the complications. And this is how to build experience. The point is, when you have no enough coils, it's not an excuse, but you need to be prepared in every time you do, especially CTO, you need to be ready with the instrument, and you need to be ready for everything, for any complications. This is my case, 72 years male, smoker, diabetic, hypertensive, and dyslipidemic with a clinical history of chest pain. In the last 6 months, he had PCI, LED 12 years ago. And after that, he do cabbage 3 grafts, 7 years. Where ejection fraction was 55%, with hypokinesia of the septum, and the vitamin stress echo shows viable reversible inferior wall. And this is his diagnostic angio. As you see, there is occluded LAD, and there is filling of the distal arteries through septal collaterals, as you see from this LAD to the distal RCA. Definitely, the RCA is a long diseased segment and calcified. And these are very good septal connections. And this is, it shows how the RCA is diffusely diseased till the nearly the mid segment of the RCA, and with good filling distally through the collaterals on the left system. And this is the Lima is patent to the LAD, and vein graft is also patent to the OM, and occluded vein graft to the RCA. So if you look for the dual injection, you will see that this part of the RCA is long diseased, calcified, and definitely reaching the crux in distally in the RCA. So this is a very long lesion. And if you look for the, all we know, the Japanese CTO score, this ambiguous cap and heavy calcification, bending, length more than 20 millimeter, and the collaterals, we have some septal, good septal, and some epicardial, and it's a Japanese CTO score is 3, so it's a very difficult scenario. And then when you look for the approach, we know this hybrid algorithm will try to go antigrade. If we fail, we can go retrograde. So this is our approach, the PCI to the CTO RCA, and then we use 2 guiding, XP 3.57 French for the left system, and M plus left 1 for 6 French for the right system. And use a microcaster MCAT with a fielder XT, who's try to antigrade wire escalation. And then we try to go through the long occluded antigrade CTO RCA, as we see. And then we try a different trial, but we see that the wire is in the branch, not in the main RCA. But here we succeed to cross in the body of the RCA and CTO segment, but still we are in a branch. And then definitely we want to be in the wall because we could not reach the RCA distally. And so we do knuckling, which is one of the important to be that with the XT in the CTO segment in the RCA, but now we need to shift to the retrograde. We use cyan blue, and then it was very difficult to have a lesion in the distal, in the proximal part of the LAD, and at the site of the septal branch. So we need to dilate first. We try to use a balloon, and then we use another balloon. It's very difficult because this is a very calcified LED proximal part, and we use a guide Zella 7 French. And then we use a cyan blue, try to catch this septal, and we push Corsair 150 in these septal collaterals. And if you look here, we try to use the cyan blue again, and then we try to go through the septal branch, and this was the cyan black. And then we try to catch these septal collaterals, and then we succeeded to catch these septal collaterals. But as you see, there is some prolapse of the microcaster in the collaterals. This is very important. One of the important tips and tricks, don't push this microcaster too hard because maybe you have some problem. And then we try to go antigrade. We try to balloon, we try to do reverse cut. But the point is that we have a very difficult to reach the occlusion. As we see, if you look for the arrow, you have a perforation in this septal branch. This is the site where the microcaster prolapse, and this is the cause of this perforation. And then we try to continue, and the patient is stable at that time, and wait for some time. We will look for to do the RCA because we need to try to get this occluded segment, but still we are in a branch. And then, as you see here, we try to look for the, as you see, still there is extravasation at the site of perforation. And definitely you need to select this perforation with the microcaster, and then we inject, as you see, and you see the filling of the epicardium with the, definitely there is a perforation, and the patient got chest pain, and we push one of the coils that was mentioned by Sanus, the EV3 coil, 1.5 by 3 centimeter, and we try to stop the this perforation. And now the perforation is still there, despite we are using one of these coils. But the bad thing is that we don't have more coils to close. So there is a lot of options, as we know, but I tried to think what to do. The point is, this is a magnificent gift in the cath lab. This is gel foam. It was used by the radiologist, and they are injecting the tumor, and they inject these feeding vessels. They close the feeding vessels with this gel foam. So what to do? How to do with this point is that you can scratch this gel foam, trying to get some small particles, and trying to have these small particles in and to get of some of these. As you see, I put it inside the microcaster, and then pushing by the back of the wire little, and pushing inside the microcaster. And then after doing this, you can inject with saline inside the microcaster with a small syringe, and trying to push all these particles in these collaterals. And this is a very important point, that you need to have very, very small, because you cannot push it easily inside the microcaster and then push it with the wire. As you see, this is just a demonstration to show how we did these maneuvers, and then we push these particles inside the microcaster, inside the collaterals. And then we try to get some, definitely we have a long disease dissected RCA, but still we have, if you inject the left system, you will find the perforation was closed. So it was a fantastic idea at that time that we don't have any more coils, so we can add this gel foam to and then we try to continue the point, but we have a very long, definitely this dissected RCA, use a guide cell again for the, we change the guiding because everything went out of the wires of the RCA, and then we try to investment procedure, and then we try to get some to maintain the flow in the RCA with and stent the proximal and mid part, and postpone this case later on after stabilization of the case, and we stabilize the proximal and mid RCA. We have some flow in these branches in the distal RCA, but still we need another session to complete this case, definitely after stabilization of the patient. As you see, there is no any problem that occurred during the after perforation and the correction of the perforation. Thank you.